They should see your face too. Yes, there. I'm going to do is tackle your hair. Good luck with that one.
Good morning.
Good morning. Toyin, I didn't realize you had long hair.
It's a wig.
It's a wig?
Yeah.
Really good.
Good.
You're welcome.
Yeah, it's like teacher. Like
Dog.
First, are there any questions or concerns?
what?
I actually messaged you last night.
If you did, I probably didn't respond. What was it about?
Can you text it all?
Let me pull it up.
That she's praying for us and good luck and all that.
It was for lab exercise 27. I don't know if we needed to do that, but it wasn't
Yeah.
open.
It's still what you know what? I thought I opened it up.
Say something mean, Mike. Yay.
I thought I opened it up. If you, I will, for everyone who didn't get it done, I'll put out an extension on it, but I'm not gonna do it until after lab today. The case studies, if you didn't get them done, just turn them in now, or turn them in whenever. They don't have a due date on them on D2L. They're not gonna close. Other questions?
Yeah, I was just experiencing the same thing. After you sent me that email yesterday, I still wasn't able to do mine too.
Okay, I will, yeah, I'll extend them out and I'll extend them out for another week.
Okay.
But I thought, I'm still learning Wiley sometimes. And I thought that if I just changed the date for the whole class, it would allow me, but maybe I have to manually do it for everyone, which is fine. It's just the way it is for Wiley. Other questions, concerns?
Any questions or concerns?
I have I have to be, I don't know if I'll be here for all of lab. I have a family emergency. I have to fly to Chicago. So
All right.
So yeah, so I'll stay as long as I can, but my flight leaves around 5 something. So just so you know, if I tag out early, that's why.
I understand. I hope everything goes all right.
Oh yeah, it's been crazy. My son came home last night. He got hurt at work, so now he's at Concentra. Yeah, it's just everything at once. That's how it always goes.
Gotta keep life adventurous.
Yeah, why not? So I get a quick trip to Chicago. Why not?
Quick unplanned trip to Chicago.
Yeah. So hopefully it everything will go well. So yeah, I just wanted to let you know, if for some reason I tag out early, it's because I need to get moving.
And you know what? The thing is, I don't even notice. So I mean, I probably would notice with you, Becky, but I don't notice a lot of it.
Yeah, I just wanted to keep you in the loop so that you're not like, okay, where'd she go?
You know what? I have students who come in late and they apologize. I'm like, I didn't even realize. I didn't even notice. It doesn't matter.
Yeah.
I mean, it's the same when I'm teaching face to face. If students come in late, I'm not going to notice. I'm not even going to take notice of it. All right, let's finish the lymphatic system. We're almost there, and then we'll move into the heart. And the heart should take us all of today and part of next time, but not the whole time, I don't think. We'll find out.
I just want to let you know too, I'll be leaving too. I'm exhausted. I got stuck at work, so I will be leaving to,
You know what,
to get
Zena?
some sleep.
I expect this from Becky, but I understand.
Thank you. I'm sorry.
Yeah, I expect this from Becky, but I don't expect it from, you know what? All right, never mind. I'm just gonna be quiet. Let's see here.
Quit tormenting Becky.
Were you all talking?
No, we weren't saying a thing.
When I popped in, were you all talking about the EKG lab through Wiley?
No, what's wrong
Oh.
with the EKG lab for Wiley or lab exercise 27?
Maybe that was it. I can't
Okay.
remember.
I'm
Was it
gonna, Claire, I'm gonna extend it out.
Okay, cool. Thank you.
Okay, and I'm gonna do it right. I thought if I just made a whole class extension, it would let me. And no, it's not willing to do that. I have to go in and manually do it. It's not a big deal. It's just what I have to do. Just a sec here. Oh, yeah. 96. Mother, I'm teaching. My mother's here crying over upset. We won't say anything. It's an important flat though.
I just bring them in the house and they die.
She brings them in the house and they die. All right, let's see here. Almost there. Okay. So I think we were about right here. Maybe let's pull up to about right here. Okay, be right here. So anaphylaxis, actually, let's start right here. Immediate hypersensitivity. Chemical mediators for immediate hypersensitivity are histamine. What leukocytes are going to be secreting histamine? Somebody remember what leukocytes are secreting histamine? Go ahead.
Is it T lymphocytes?
Nope, not
B?
histamine. Nope.
Oh.
Not histamine.
Eosinophil.
Eosinophils, and actually is it eosinophils? Yep, they would be secreting it. What other lymphocytes would be secreting it? What ones are most famous for secreting it?
Stem.
Nope.
Basophil?
Basophils, yes. So it is eosinophils, and whether, I don't believe they secrete histamine, but they are involved in the immediate hypersensitivity. So they might. Another one that we really have not talked about, but it is a chemical mediator of immediate hypersensitivity, is slow reactive substance of anaphylaxis, SRS. What does, if you think about it, what does an eosinophil chemotactic factor mean? What does it mean to be chemotaxis? What does chemotaxis mean?
Kills by chemicals. Right.
You're
Or-
close, but no. What does it mean what does chemotaxis mean? Bear with me.
Is it
What does chemotaxis mean?
One is chemical.
Right?
Axis is
toxicity?
Nope. It sounds close to that, but it's not. What does it mean? It means to move towards something or moving towards it. And when it says moving, taxis means to move towards something. Chemo means a chemical, like I think Zena said. So chemotaxis actually means to move towards a chemical. So with that in mind, a eosinophil chemotactic factor, what would you guess that might be, what its role may be, even though we've never talked about it? What do you think it might be?
To move towards the eosinophils.
Or what else? What else? You're close. What about a factor that is a chemotaxin for eosinophils? Does that work too, Becky? She says maybe.
Yeah, I'm a little brain dead, so I'm just
You know what? I understand that kind of thing. But so what this is it's a chemotaxin specifically for eosinophils. But it's got a name, and so it's called the eosinophil chemotactic factor, meaning it's a siren saying this is where we want eosinophils.
It's almost like a beacon type of thing.
Yeah, it's a beacon. That's a good way to put it.
Okay.
So symptoms vary depending on the site, allergen, and mediators involved. You can get hay fever, asthma, hives. Anaphylaxis is an anaphylactic reaction is an immediate acute hypersensitivity. It can be delayed with antihistamines. In contrast, anaphylactic shock is a severe widespread acute hypersensitivity. So anaphylactic reaction is local. Anaphylactic shock is severe and widespread. It's characterized by bronchoconstriction, dyspnea, I think that's how you say it, dyspnea, which is difficulty breathing. Widespread vasodilation, so blood vessel, all blood vessels all of a sudden open up. They were any blood vessels that were constricted before are now dilated. And the result is that you get circulatory shock from widespread vasodilation. It's a major drop in blood pressure. We'll talk about that in the next 2 weeks or so in lecture. It's a major drop in blood pressure. And sometimes sudden death. So bronchoconstriction, meaning you're difficult, which results in difficulty breathing, because all of a sudden you can't bring air in and you can't get it out, because all the bronchi are constricted. Vasodilation, all of a sudden the pressures drop, your blood pressure, because all the vessels decided all at one time that they would open up when some of them were constricted, because that's talk about why that's important later. But all of a sudden all of them are opened up, so you're dealing with circulatory shock because there's just a major drop in blood pressure, so the blood isn't able to flow right. Symptoms, you can't treat this with antihistamines, it's too severe. Antihistamines don't work that fast. But you can possibly relieve it, or symptoms can be relieved by epinephrine. What's epinephrine? Talked about this last semester. What's epinephrine? What's epinephrine?
Is it a bronchodilator?
A bronchodilator.
But it makes it do that, maybe.
It does, because it probably is gonna. You're right. It's probably gonna release. It's going to
It's a hormone.
right. And what else is it?
Oh, it's adrenaline.
Adrenaline.
It's adrenaline.
Yeah.
And what and meaning it's a neurotransmitter, right?
Yep.
Right. And you're right. It's going to work in actually the opposite direction. So does it work on the sympathetic nervous system or the parasympathetic? Guys, think about this for a minute. Remember what we talked about from last semester. What does the parasympathetic nervous system work on? What does it do? Or the autonomic, actually.
It
Fight
calms
or
the nervous system down
Yeah, what?
through a it's in a negative feedback loop.
It's going to work on a negative feedback loop. If you go back and you look at the autonomic nervous system, bear with me here just for a second.
Well, it's the fight or flight one.
It is.
I
It
just
is.
can't think of which one that is.
Yeah, the rest or digest.
that's it. Isn't that
The rest
para-
of digest, yes, it's the parasympathetic nervous system. Bear with me here. Doesn't go into. I think it's here. Find out there. Yeah, there it is. No, I may be wrong in explaining this because I didn't plan on it, so I didn't study up on it. But I think if we're looking at this, oh, it's back here. So this was the PowerPoint on the autonomic nervous system. Okay, so sympathetic nervous system, heart rate increases, bronchioles of the lungs dilate. This is your fight or flight. This is where you're fighting. Okay. Parasympathetic nervous system, heart rate decreases, bronchioles of the lungs constrict. And it doesn't say it here, but your blood vessels, oh, do they? I want to say they constrict. I don't think let's go with what Kevin said, but recognize that it's because it's what does epinephrine do? Kevin was right, it's a bronchodilator. But why is it a bronchodilator? Because it's working on the sympathetic nervous system. It's a hormone. You know, why do drugs work the way they do? Why does an EpiPen work the way it does? Is because it's activating the sympathetic nervous system. Does that make sense, Kevin and Becky?
Yes.
Hi. And one thing that I'm realizing this may not work so well for is the blood vessels, because blood vessels actually dilate with the sympathetic nervous system, at least some of them do. But this is the reason the epinephrine works like a bronchodilator. So delayed hypersensitivity occurs through direct action of sensitized T cells. So this is an adaptive immune response. This would be, anaphylaxis would be an innate. Actually, no, I'm sorry, it's both. Because we know that IgE is adaptive. Mast cells are innate. So this is an interaction of the two. And let me, bear with me here. I am going to, I thought I was going to start delayed, but I think let's finish this. So how does immediate hypersensitivity work? Allergens enter the body for the first time. Those allergens bind to B cell receptors that you've been previously exposed to. These are memory cells. So the you've been exposed to before. I'll tell you, several years ago, I wasn't around for this. Luckily, my mom was, though. She got it firsthand experience. So one of them really interesting, she used to, you know about my little teaching assistant here. I'm going to show you face. See, so I even got my hair comb for my ears and my face wash for class this morning. Which never happens, but she chose that it was important this morning, or my mom did, one of them. My mom used to breed toy poodles, and they had an experience where a dog developed an allergy to anesthesia. So what happened was that, you know, occasionally, you know, you don't breed, this little one is a toy poodle. You don't breed teacups. You remember this. Don't breed teacups. Hypersensitivity, but it was anaphylaxis. It was, if she stopped breathing, like she did. It was anaphylaxis. We'll talk about it later, but I'm pretty sure that's anaphylaxis. My mother's saying no, it wasn't. But what happened was the dog, when you breed toy poodles, it's not one of those things where you walk away, and which is can be anaphylaxis, but it wasn't. All right, we're not going to go into all that. When you breed toy poodles, you don't walk away when they're in the middle of delivery, and because they're smaller dogs, and so there's more likely to be complications. And if you don't want to lose your mama dog, you don't walk away. You wait out the delivery. And the dog started having problems, and she'd had a C-section before, and so they went in to have her do a C-section. And when they gave her the anesthesia, she went into, my mother says, respiratory and circulatory shock. And what they ended up doing was giving her epinephrine and bringing her back. And she was fine, but she'll never have another surgery again. She ended up being adopted out to a family who knew that she'd never be able to be spayed at that point because of the fact that she developed an allergy to the anesthesia somehow. So it can happen that easily. It can be the second time you get exposed to that allergen and you go into anaphylactic shock. So I'll tell you another weird one when it comes to allergens. I don't know if I mentioned it last week. I have a good friend. She's kind of my partner in crime for A&P. She anatomy and physiology learning. She has an allergy to Benadryl. The almost general everyday antihistamine she can't have. So allergens bind to B cell receptors. The B cells now process get and with the stimulation by T helper cells, develop a memory cell. You get some plasma secreting cells and you get some memory cells. Remember that you only get the memory cells through the help of the helper T cells. And the clonal expansion has to do with the fact that only the B cell receptors, the B cells that have receptors that bind to that specific antigen are allowed to proliferate and become plasma cells and memory cells. Activated plasma cells of the B clone specific for each allergen then secrete IgE antibodies, which are active against the allergens. The next time that you get exposed, the FC portion, remember this is the back portion. You've got if you're looking at an antibody, the FC portion is the constant fragment. Think of F as being fragment, C as being constant. This is the constant fragment, which is the same for every IgE antibody. The Y branches here are the FAB, meaning the variable parts that are antigen binding. So the FC portion of the IgE antibody, regardless of the specificity of their FAB, binds to an IgE tail receptors on mast cells. So cells have a specific receptor for IgE. Remember the FC portion of the antibody is what's going to dictate what's going to happen to those specific antigens, those specific antibodies. It's going to dictate. So the same thing, it's going to determine how the body's going to respond to that antibody. And remember that the FC portion is the same for every antibody of that specific class. And there's 5 classes of antibodies. So the IgA antibodies have one specific FC portion, all of them. IgG have one specific part. IgD kind of, because it's also the B cell receptor. IgM and IgE. So the IgE tail receptors on the mast cells and the basophils bind to the IgE FC portion. And then the mast cells become activated when the IgE tail binds to it. And the result is that you get a massive release of histamine. Guys, is this clear? Maybe.
Yes.
So allergens activated, B cells get IgE antibodies. The tail portion of the IgE antibody that binds to its allergen binds to the receptor on the mast cells, and there's a massive release of histamine. Delayed hypersensitivities occurs through direct action of sensitized T cells in response to an antigen. So this is rather than IgE antibodies, which are coming from B cells, we're now looking at T cells. Usually occurs 12 to 24 hours. And it's delayed because T cells take longer to react. So comparison and contrast, immediate hypersensitivity, usually within 20 minutes. Delayed hypersensitivity, 1 to 3 days. Immediate is antibody-mediated immunity. Delayed hypersensitivity is cell-mediated immunity. So remember, cell-mediated is T cell mediated. Immune effectors involve B cells, in immediate hypersensitivity is B cells, IgE antibodies, mast cells, basophils, histamine, slow reactive of anaphylaxis, and eosinophil chemotactic factors. Delayed hypersensitivity is T cells. So bronchoconstriction and widespread vasodilation are all characteristics of what?
B, anaphylactic shock.
Correct. So this is just a summary slide. Different things involved in adaptive immunity. Last part of this. Pus is broken down macrophages. So they go and they eat, they're busy doing phagocytosis. They're taking in lots and lots and lots of stuff. And then they die. And that's what pus is. So it really, it is a sign of infection, but it is an infection. It's a sign of it. Because the macrophages have done their best to get rid of the infection. Defenses before I want to go back. I would prefer with this one, this definition. Plus, because we've talked about macrophages, that's a pretty easier definition, but I want to. Defenses. They were on here. Actually, let's do the leukotrienes first. Leukotrienes are eicosinoids. Remember from last semester what eicosinoids are. Eicosinoids are lipid-derived structures that are going to stimulate vasodilation, capillary permeability, and neutrophil chemotaxis. So these are not, this is specifically innate immunity. Prostaglandins are another eicosinoid that are going to stimulate pain, fever, and vasodilation, neutrophil diabetes, and enhance inflammation through histamine and bradykinin action. Bradykinin is a kinin. Kinins are small polypeptides. Bradykinin stimulates vasodilation and capillary permeability and stimulates pain receptors and is a neutrophil chemotactic factor. And I'm trying to remember what defensins are. You know what? We knew what they were until a second ago. And I thought they were on this list. They work with the innate immunity, and they enhance the activity of macrophages. So defenses, leukotrienes, prostaglandins, all involved within innate immunity. Immunocompetence We talked about this during the PowerPoint. This is specifically when a B cell or T cell is mature enough that they leave the bone marrow in the thymus, and they can develop an immunitory response. Naive B cells and T cells, meaning they've never been exposed. They're the ones that are floating around just waiting for the chance to be able to eventually possibly meet their antigen and get activated. They've never been exposed to the antigen that they're made for. Viruses, how does that work? Remember that viruses are found, they're the ones that are killed by cytotoxic T cells and possibly natural killer cells before. But they are presented by MHC1 receptor holders because you only find virus infected cells in nucleated cells. So they're displayed as self-antigens. Antigenicity is how well does an antigen, any given antigen, how capable is it of binding an antibody? The more complicated it is, the better an antigen is. Interleukins, remember inter meaning in between, leukin meaning leukocytes. Interleukins work in between leukocytes, like interleukin 2, which T cells use to help stimulate memory cells. T helper cells use them to stimulate memory cells in B cells and T cells. So these are chemicals that work in between the leukocytes. That's where the name comes from. And reticular cells, another one that I'm losing. I should have known what this was. Reticular cells are the cells that secrete reticular fibers. Where did we find reticular fibers? Remember what reticular means? Reticular means a net or a filter. So we find these in the spleen and the liver and the lymph nodes. Questions? I'm going to go through some of these. We're going to avoid some of them, but just for time wise. What could account for the symptoms? You get vaccinated and you develop, I know I got this, I think with the first COVID vaccine I got. An account for the symptoms that could occur in the injection site when someone is vaccinated against influenza. Or COVID vaccine. You get that big swelling. What could account for the symptoms that occur in the injection site when one has been vaccinated against influenza? What about your innate immunity? You get a major swelling, all the signs of inflammation. You get increased vascular permeability, increased blood flow to that area. Neutrophils and monocytes move into the area. How could infectious organisms circumvent the phagocytic defense mechanism? Well, infectious organisms, one thing that the phagocytes have to do, go back and look at the pathway of phagocytosis. All the way back, 107. Well, one way that they might is remember that the phagocyte has to bind to the microbe, meaning there has to be certain receptors that the phagocyte is capable of binding to. So what if there's no receptors on the microbe that the phagocyte is able to bind to? What else? Some pieces with. What if the defensive, the pathogen looks so similar to the cells of the self or your cells that it doesn't trigger phagocytosis at all? It's not even detected. Kind of like a Trojan horse. Guys, if you have thoughts on these questions, please chime in. Neutrophils of people with Chidiac-Higashi syndrome have fewer than normal chemotactic receptors and lysosomes that spontaneously rupture. What are the consequences of this syndrome? You guys, what do neutrophils do? What's their function?
They detect foreign invaders.
They detect foreign invaders, and what do they do with them?
Don't they notify like other cells to phagocytize them?
But what do they do before that happens? Wait, you're close. What's their major function, Claire? Go back and look at the neutrophil slide itself. I'm trying to remember if it was even on this.
Isn't it to activate the natural killer cells?
It's, say it one more time.
It's to activate the natural killer cells.
Well, it could do that, but what by itself, what is it capable of doing before it activates other things?
It heals the damaged tissue.
Say it again.
It heals the damaged tissue.
How does it kill it? What does it do?
It heals it. Heal.
Well, how does it kill it?
No, I said heal. Heal. HEAL.
HE. Yeah, but how does it do it? How does it do it? It does it through phagocytosis. So it's one of the main, it's the specialized phagocyte. If it has less lysosomes, what is that going to do? What do the lysosomes do in phagocytosis?
They kill the cells, the foreign invaders.
Right. So once the thing is, whatever the microbe is, once it's brought in, it fuses with the lysosome and the lysosome destroys it, right, Claire?
Yes.
If neutrophils have less lysosomes, what happens to their ability to perform phagocytosis?
It goes down.
It goes down. What does it mean if they have less chemotactic receptors? Why would that matter?
The ability to, it would slow down the ability to
what?
To fight or kill or
What
eat.
does chemotaxis mean?
It means chemical movement.
Okay, so moving towards a chemical, if they have less chemotactic receptors, are they going to be able to move towards chemicals as easily?
No, their movement slows down.
Exactly. So first thing is they're not as good at phagocytes because they don't have enough lysosomes. And they can't move towards infection as well as they should. Does that make sense? And the result is that you've really impaired localized inflammation because neutrophils are one of the leukocytes, one of the two leukocytes that is able to move through the vessels to a site of inflammation, move through the vessels to the sites of inflammation. Positive diagnosis of AIDS is made when a patient has antibodies against HIV. Why, if they're developing antibodies, do they have an immunodeficiency? Remember what AIDS infects and what AIDS actually fights against. What's the major cell that HIV is nasty against and destroys?
T cell.
Which one?
White blood cells?
No. Well, they're all white blood cells. Which
CD4.
What's CD4? What role does CD4 have? This is probably my favorite question of these questions. What?
They infection. Right?
Say it again.
They fight infection.
Well, yeah, but all T cell, all cells, white blood cells do that. But what's
immune response?
Say it again.
They help coordinate the immune response.
Yes.
By stimulating other immune cells.
Nope, 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 nope. Go back and look at the roles of T helper cells. What do they do?
It's an indicator of immune function.
It's an indicator of immune function. You're right. What what
looked it
do
up.
we it's all right. What do we really need that T helper cells do that no other cell? Okay, that's not really the right way to put it. The one thing that T helper cells do that none of the other cells are capable of doing is, first, they do coordinate the immune response. The other thing that they do, bear with me here, is they allow, if it's there, if T helper cells are there, they allow for memory cells to be produced. If it's not there, you don't get memory cells produced. You have to have T helper cells to produce memory cells for both plasma, for both B cells and for cytotoxic T cells. And so things that your body almost always keeps in check because of your immunological memory, like herpes simplex virus, the cold sore virus, Carcopes, what was it? There's a tumor, things that would normally not hurt you because your immune system has such a good memory against them because you're constantly exposed to them, are what will bring down many AIDS patients, because you quit developing the ability to develop more memory cells. Does that make sense? If you think about that, that means that every time you get a vaccine, it doesn't do anything for you because you develop no memory cells. Every time you get exposed to something, it's like getting exposed the first time.
I have a quick question. Isn't
Go.
that slide a little off? Because a positive diagnosis of AIDS is made when your CD4 count is below 200.
Well, the only thing, well, you're right there too. You're right there too. But actually, if you actually look also at other signs of it, it actually doesn't kill the T helper cells initially. You're going to get antibodies first.
Yeah, okay.
It actually can remain in dormancy for up to 10 years. A really good book, like I mentioned it several times, read that book, The Immune by Philip Detmer.
I actually looked at it at the library. My card expired. I need to renew it.
It's awesome. It's awesome. And he spends a lot of time talking about the AIDS virus. He also spends a lot of time, because another one, and I don't know if I mentioned this or not, this is the last, it's almost the last slide.
What's his name, Miss Mary?
I'll show you just. It's awesome because, you know, I don't get a lot of books in print anymore because I get everything. Are you looking for the book? It's right there. I'm looking at it so I see it. Thank you. I'll show it to you. I don't get a lot of books in print. my mom can tell you that I do almost all audio all the time because I don't sit down and read unless I have to. Because I just don't have time for it. But this is a book. And he does an amazing job explaining the immune system. One other thing that he talks about in there is, that, and most of us know that bear with me here. You don't see my screen, do you? Do you see my screen?
Nope.
Okay, just a sec. Do you see me?
Yes.
Yeah.
One thing that he also mentions in this book, and I'll quit touting about this book after this, but he mentions that he makes a mention that that people are not immunizing their kids right now. And part of it is because they're worried about getting their kids autism. If you read another book that I just finished, which was an awesome book about the evolution of autism, you realize that that has nothing to do with autism. Autism is on the rise. And one thing that comes out in this other book that I just read was that autism is on the rise because of evolution of intelligence, and that it's caused by that.
Because they know how to diagnose it now.
Well, they know how to diagnose it, but that's not all there is to it.
Yeah. And then the symptoms show up when your kids are around the time your kids get those immunizations.
Right.
So my son has high functioning autism, and
Yeah.
he's super, super, super duper smart. And but me 15 years ago, my son's almost 16, I guess almost 16 years ago, I didn't immunize him for a year. The first immunization he got was polio, and I made them separate everything. Again, I had all natural childbirths, like no epidurals, and he still, and
Let me stop you just for a second.
Sorry.
No, you're all right. I want you to finish, but this is the book. And yeah, he does an amazing job because he also talks about the pros and cons of vaccinating versus not vaccinating. And of course, he's a little biased, but when it comes to that. But Claire, what were you going to say? Finish what you were saying.
Oh, I was just sharing a personal story, but no, I'm just telling you, like, I did all of the right things, and like my son was like a vegetarian the first year of his life. I did all these things, and he still has autism. So I think there's like a genetic component.
There is, and I don't, what comes out in this book, let me see if I can find it. What comes out in this book, and I'm not saying these books are exactly right, but the people who have written these books have done a lot of research into them. This book called Neurotribes, The Legacy of Autism.
I read that. That's a good one.
Isn't it awesome?
It's awesome. Yeah, it's really good.
But one thing that he brings up is if you look at some of our major geniuses that we've had in history, a major percentage of them are autistic, are on the spectrum. You look at Albert Einstein, you look at Thomas Edison, you look at, there's another one that he really mentions, Tesla. We all know what Tesla is. Tesla in physics, I've been trying to remember what it means. This man, Nikola Tesla. I did some the unit of magnetic induction in physics is named after him, was very, 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 very highly autistic.
Tesla was?
Yes.
Really?
Yeah, go back and reread some of that book, Claire, because he's mentioned in there for like a couple of chapters.
Okay, I haven't finished it. I'm like 75% maybe
Get
through
it
the book.
audio and you'll finish it a lot faster, I promise.
I only do audio because I commute an hour
All right,
each.
go
work.
if you have Hoopla, it's on there and it's awesome.
I have it on my Audible, but yeah, no, I
Okay.
need to finish it. It's so good though. It's so good.
But one thing that he mentions is he says, you know, the guy who just discovered Asperger's, he's the one who first noticed how smart these kids were. Because he used to call the patients, the children that he worked with, his little professors. Because he said, if you got them started and got them, you know, primed them for what they were so, what's the word for it, obsessed with, they would take over the world with what they learn about.
Oh yeah. I feel like I'm raising young Sheldon. Has anybody watched Young Sheldon? I mean, he hasn't dismantled my refrigerator yet, but he's really smart. He has some, like, I don't know if this is probably another topic, totally off topic, but I feel like
To my world.
the school, like academically, he does very average, but like he has like a photographic memory, and I just feel like school isn't measuring his intelligence the way that, I don't know, is that making excuses for him?
No, it's not. And
Okay,
schools, the one thing that also comes out in that book is that schools are not, we haven't gone, we keep wanting to cure autism rather than realize that it's not going away.
Right.
No.
And making autistic children think that there's something less.
Right.
Because it's not the case.
My son is in the academic club.
Yeah.
And because he's like super smart with facts, but he'll be the first to be like, yeah, the only thing I can do with this is bar trivia. He has no brain filter too. My son has absolutely no brain filter. He'll tell you as it is.
I think that's just a 16-year-old boy though. I have one at home and he has no filter either.
Like,
so
you're not allowed to say that to me. That's what I tell you. You're not allowed to say that to me.
Let's come back. Let's finish this out.
Okay.
But yes, I think, you know, there's a lot out there, and I think people who are autistic should play to their strengths.
Mm-hmm.
Claire, the kid's going to be fine. When you get him into college, get him into his ADA accommodations and get it done immediately. He's going to be fine.
Thank you.
One more thing. I watched that doctor show with the doctor.
The Good Doctor?
Yeah.
I just heard of that. I've never seen it, but I heard of it.
Oh, it's great. He has autism.
Wow.
It's so good. It's so good.
Okay, so you
what
get
is that called? Sorry.
The Good Doctor. The Good Doctor.
Okay.
Okay, so you get a flu shot each year to protect against the flu. Why don't they just give you booster injections? Why doesn't last year's flu shot protect you against this year's flu?
because it like changes every year.
Different strain.
The strain is different every year.
It
So just a
mutates.
simple booster isn't gonna work.
It mutates.
I knew there was a big word for it, a fancy word.
It's the same reason that we're seeing the same thing for the coronavirus. If you look at it, it's the same thing. I get frustrated when people say, and I won't get political on you. I get frustrated when people say, well, you know, why do we now it doesn't work. So what are they saying? And I'm like, people, it's science. It's a virus. You know, welcome to the realities of life. It doesn't, it's not, it's going to mutate.
That's what it takes to survive.
Right, exactly. And, you know, we can't, I just feel like it's one of those debates where you can't argue with science. But all right, any questions about the immune system? That was the last slide. I do love this class. We have a good time in here. I do. It's by far probably my hardest class to teach this semester because I'm new to teaching it. But I enjoy the discussions.
I feel you do a good job, so that's.
Well, I'm glad because I feel like I'm kind of going by the seat of my pants half the time when I can't tell you what a defense is.
That's life. We all fly by the seat of our pants some days.
I'm doing it more with this class than I do with other classes, I can tell you that. I'm getting better at it, but it's always an adventure. So let's talk about the heart. I'm not going to spend a lot of time on heart anatomy because that's one part of it, but we had a lab focused on it. I want to spend the majority of this talking about other parts of the heart and the physiology of the heart. But we will go through it a little bit here at the beginning. So the circulatory system is the transport system of the body. There's three basic components. You have the heart, which is a pump. You have blood vessels, which are passageways. You have blood, which is a transport medium. The main purpose of the heart is that it generates blood pressure. Remember, everything moves from a high to a low. So the whole reason blood flows is because the pressure is higher and it flows to a lower pressure. One thing that I want you to think about a lot over the next 2 chapters is that blood is like water running through a hose. And so when we look at blood running through vessels, think of it like when you're watering your garden. If you have very low pressure, what happens to the water flow? When you have very low pressure, what happens?
It trickles out.
It trickles. Do you get much flow?
No, minimal.
Right. Well, it works the same way for the blood. So the heart generates blood pressure through alternate cycles of the heart wall's contractions. Systole is heart contraction. So systole, diastole is relax. So systole, heart contraction. Diastole is heart relaxation. Blood pressure is the force of the blood pushing against the walls of the blood vessels. Another way to think of it is blood pressure is the hydrostatic pressure. Hydrostatic pressure. We'll talk about this in lab today too. Hydrostatic pressure.
I had preeclampsia when I was pregnant
Yeah.
and I had to go bed rest. But like the doctor told me that if like my blood pressure went up, that it would like pull the my blood would go through the placenta so fast that it would rip the placenta away from the uterine wall. So she was,
Wow.
yeah, and that's what happens, and you're like at risk for blood clotting, strokes, death, your baby's death. Like it's really
Is that why it's so deadly and why it's so nasty?
yeah, well, because you could get like the blood, it could also like explode a vein in your brain. Like if your blood, like think about it, if you put water through a hose so fast that it like
Right.
broke the hose, it's like the same with like your blood.
Yeah.
So I don't know, that scared me enough to stay on bed rest.
Well, and see, I didn't ever know that. I knew that it was bad. I knew that it was blood pressure issues.
Yeah, so basically, and it
But
could
that
affect
makes
like
sense.
your baby and all that. So yeah, and then after 3 weeks after I gave birth, which is the cure for it, right? Preeclampsia.
You
I would
get rid of the baby.
you
Okay.
get rid of the baby. I was at risk for a stroke up to 3 weeks. They told me that I needed to, be monitored.
That happened to my friend. Her placenta actually erupted. And
That's scary. Is she okay and the baby too?
well, he came super early. He's fine now. He's 7. You wouldn't
Good.
he was a preemie, but it happened like so fast. And luckily she was at the hospital when it erupted, so they saved her, but she could have died.
Wow. Wow.
And she didn't know that she had high blood pressure the whole time.
Yeah.
Wow. See, I didn't know that. I knew that it was bad, but I didn't realize just why it was bad. Okay, so blood pressure is the force of the blood pushing against the inside walls of the blood vessels. So think this is the hydrostatic pressure of the blood. A minimum blood pressure is essential to circulate the blood throughout the body. The further the blood pressure gets, the further the blood gets away as it's moving through your pathways and your tracts of blood vessels, the further it gets away from the heart, the lower the blood pressure. Remember that for later today in lab. So systolic pressure goes, so heart generates pressure through these alternate cycles. In the systolic phase, the blood pressure rises and the blood moves along the vessels. In the diastolic phase, the heart relaxes and the blood pressure falls and the blood fills the heart. Rachel, I'm getting your message about your mic not working, but I'm going to look really quick and actually read it. Yeah, I noticed, Rachel, you're just being quiet. I think you planned for your mic not to work. And the nice thing is she can't really say anything because her mic's not working. I understand, Rachel. So pulmonary circulation versus systemic circulation. Pulmonary circulation shunts the oxygen-poor blood from the heart to the lungs to be resaturated with oxygen and returns the oxygen-rich blood back to the heart. Systemic circulation is going to deliver oxygen-rich blood away from the heart, deliver it to the organs and tissues, and then return the oxygen-poor blood back to the heart. Let me say this one more time. Pulmonary circulation is going to shunt the oxygen poor blood from the heart to the lungs to be resaturated with oxygen. And it returns the oxygen-rich blood to the heart. Do you guys remember what arteries, by definition, what are arteries and what are veins?
One brings blood towards the heart and one brings blood away from the heart. And
you guys, I'm sorry, we're gonna take 10 minutes. My family had a little bit of an emergency last night and my mom's in there talking with my sister-in-law. Let's take 10 minutes right here. We will come back to right here and go from here, but I want to hear what's going on.
Okay.
I told you, if you had me last semester about my niece putting her fingers through the glass pane.
Yeah.
Well, my nephew decided to do this, something very similar last
Oh my
week.
gosh.
And so I want to go see what's going on. And this is by far if you want to play favorites, he's my favorite nephew. He's great. And I want to hear what they're talking about. So I'm sorry. So let's take 10 minutes here. I'll be back.
break
Sounds
will be
good.
nice. Thanks.
Okay.
Hopefully all is well.
He'll be fine. I saw pictures of him last night. He'll be fine. But I want to know what's going on. I'm here listening to the station. Yeah, I'm having class in the other room and then I'm hearing Bob talk about an injury and I'm like, she's talking. No, she's. So I said, you have to take a 10-minute break. See, we know he's the boy after my own heart. Has he got any nerve damage, Keisha? How did you do this? I'll yell it. Well, that boss was kind of she's a yeah. Ace have access to his phone?
Yes.
All right, I'll text him.
Yes, please do. He would be happy to message Dr. Thorpe that he's cracking jokes left and right. Checks how check that he had PTSD. And so he was like, what is that? And so I was like, and he goes, I was like, Ace does not have PTSD. And so I was explaining it to her. And she got lost in the room. He's like, dude, that's just for you. So, and then when I said the features of his hand looks like it's whenever he's in the mood, it's very blonde. Why not? Last night, he's like, it's blonde, and he turned all right to toe. So, yeah.
That's awesome.
When you have that kind of support, it's hard to get from people.
I know, right?
When you have instant care and instant support, then these things happen.
Yes. Yes. But I did tell my brother about it and he knew one about how he needs to be more synchronized. And I was like, you're totally right. You are totally 100% right. He's like, I'm really sorry, they overstep my bounds. I was like, no,
This is the child who has no kids.
This is the guy who has no children.
I'm sorry. All right, that's funny.
he's like, how do you grow? I was like, you were free range last Tuesday. That is terminology of how we raised, how we survived. You know, but we did.
Well, I'll tell you, looking back on the school as I did, and yeah, probably. Right, but it's amazing.
Yeah.
All right, I gotta go back to class. Love you, Daisha.
Love you, Mary. And Jackson, he's early fall.
Jackson, well, I kept thinking, did he just get a lot taller?
I couldn't help it.
You're funny. All right, love you.
I just couldn't help it.
Okay, I'm back. Yeah, I apologize for that. I'm listening and I thought that this injury happened about 10 o'clock last night. And I needed to finish getting ready for this class. So I was like, and they weren't ready for me to type their phone line. But my nephew, they didn't tell me how it happened, but he cut through the tendon on his finger. Who knows what he did.
That worked out because I just got off the phone with my son who had a workers' comp accident. So they're sending him for a CAT scan.
What did he do?
He works general construction. My gut is, I think it's some sort of a hernia, but he felt a huge pop and severe pain in his abdomen. So I have no idea. He's 19. It's like, and of course, and I'm leaving. So it's not like I'm going to be home to deal with any of this.
Okay. Wow.
Yeah. So that worked. I just took a break and hung up with him. So they're sending him for that. He doesn't know when that's going to be. So we'll see.
Wow.
Oh, life. So
Yeah.
fun.
So pulmonary circulation. Arteries take it away from the heart, veins bring it back. With that in mind, the pulmonary arteries are the only ones that are carrying away oxygen, poor blood from the heart, because they're taking it to the lungs to get oxygen rich, saturated. And the pulmonary veins are the only veins that are carrying deoxygenated blood, oxygenated blood, because they're bringing the blood directly from the lungs back to the heart. That's a really good exam question that a lot of students miss. So systemic circulation delivers oxygen-rich blood away from the heart and delivers it to the organs and the tissues, and then returns oxygen pour blood back to the heart. The heart is located, it's about the size of your two hands together, two fists together. And it's located on the left side of your chest, mainly on the left side, in what's called the mediastinum. The mediastinum, and I don't see it on here, so I'm going to change slides really quick. Mediastinum. Mediastinum. So mediastinum within the pericardial sac. It's angled so that it's the apex is down towards the bottom. Apex, if you think of what apex means a point. And in the case of the heart, it's the bottom point. The base is at the top. If you remember from when we did the dissection 2 weeks ago, the heart looks kind of triangular, conal in shape. That's important when you think of how the blood is going to leave the heart. And we'll see that in a second here. The apex is closer to the surface, the anterior surface of the chest, with the base more towards the back. So it's kind of like, here's my base. So it's kind of like this, and my apex is right here, coming out towards the anterior surface. Coming out towards the anterior surface. And it's kind of oriented back and off to the left. It's important when you're trying to listen to heart sounds later, to recognize that the tip or the bottom of the heart is more superficial than the top of the heart. The heart is enclosed within the pericardial sac or the pericardium, where the outer layer is the fibrous pericardium. The inner layer is the serous pericardium. So fibrous pericardium, serous pericardium. The serous pericardium has two layers: the parietal pericardium and the visceral pericardium, which directly lays on top of the heart and is, part of the heart. When we were dissecting the heart, the surface of the heart is the visceral pericardium. You're looking through it when you're looking at the heart, surface of the heart. The other name for the visceral pericardium, because it is the top layer of the heart or the top layer of the heart muscle, is the epicardium. Remember what, and this is the way it is all the time, guys. Remember this for all of the membranes. Visceral means organ, so it's the layer that's going to be directly on top of the organ. The space between the parietal and visceral pericardium is the parietal cavity that has normally has 15 to 50 ml of fluid within it. The pericardium functions. It protects and anchors the heart in the thoracic cavity. It prevents overfilling or overexpansion of the heart when the blood volume increases. So it's a tough layer. It's like the dura mater that surrounds the brain. It is a tough layer. It's not stretchy. And the result is that the heart can't overexpand that area. It allows for the heart to also, because of the lubrication of the serous fluid in the pericardial cavity, it allows for the heart to work in a relatively friction-free environment, with the pericardium working as a shock absorber. One thing that we should talk about here that's an interesting thing to think about is pericardial effusion. This is fluid buildup around the heart. Why would this be an issue? Why would it even be a big deal for you to have fluid buildup around the heart?
Would it interfere with the contractions?
How would it interfere with the contractions?
Doesn't it have something to do with like, it would prevent like the heart chambers from filling completely with blood?
Why? You're right, but why? You're both right, but why?
Because that water is taking up space that the blood would take up? No?
Close, but not. Close, but not.
Poor blood flow and maybe like a lack of oxygen.
Well, let's look at it this way. Do you see the picture that I've got right here?
Yep.
So you have this area, you have this loose balloon, and your heart fits within it. The more fluid you put out here, the less the heart can fill. Does that make sense? Because this fluid is pushing on the heart, right? This fluid is going to be pushing on the heart.
Okay.
So the more fluid you have there, the less stretch the heart is able to make to allow for blood to come in. And we'll talk about why that's so important, probably next week. But if you can't get, like you, Kevin, like what you said, and it's also what Jade said, if the heart isn't able to fill up because it can't stretch out, it can't expand out against the pressure around it, it's not going to be as effective of a pump, and it's not going to, the amount of blood that's coming, it won't be able to contract as strongly either. It's a lot of different things, but the major thing is, no, it's not going to be an effective pump because it's not going to be able to fill up. It's not going to be able to expand out. And the less blood you can get into the heart, because it can't expand out, the less blood that it's able to pump. Does that make sense? Somebody tell me yes or no.
Yes.
Okay. So fluid buildup around the heart can result in pericarditis, which just think of that. Don't think too hard about it. Itis always means inflammation. Pericard meaning inflammation of the pericardium. My little sister struggled. Oh, actually, I'll hold off on that one for right now. Causes infections, viral or bacterial, such as tuberculosis, inflammatory diseases, rheumatoid arthritis, or lupus. Cancer that has metastasized to the pericardium. Kidney failure with excessive blood levels of nitrogen. And heart surgery. Looking at the external heart, looking at the anterior view. Right ventricle, left ventricle. We're going to view it, zoom in just a little bit more here. Right ventricle, left ventricle, right atrium, left atrium, and on top of the two atriums, the right auricle, the left auricle. Remember when we did the heart anatomy, that the way that I can always determine the front of the heart from the back of the heart is the auricles are just like your ears, they bend forward. So they bend towards the front. Auricles are essentially an extension of the atria that underlie them. The inferior vena cava and the superior vena cava and the coronary sinus that runs around the back of the heart are what's going to drain blood into the right atrium. The aortic arch. If you remember, and I'm not sure if we've done it in here, but I know some of you did not. I know at least half of you didn't have me for 121. If you want to do something interesting and only do it to yourself, don't do it to someone else because we don't want to hurt somebody. But here's your sternum right here. Stick your fingers right behind your manubrium here. And you want to go in fairly deep, and this is why you're only doing that on yourself so you don't hurt somebody. Put your fingers fairly deep there. Stop talking for a second. You have to stick them fairly deep, almost to the point of where it hurts. Do you feel the pulse? Somebody who didn't have me last semester, say yes or no.
Yeah.
Why do you think you feel a pulse right there?
Is it because that's where an artery is?
It is, and what it actually is your aortic arch is probably within about an inch of there. And that's why you feel such a strong pulse right there. So it's coming out and then it's going down your body and going out towards your abdominal organs. Your pulmonary trunk coming up from the right ventricle, branching off into the left pulmonary artery and the right pulmonary arteries. There's this little structure right here called the ligamentum arteriosum, which in embryos is called the ductus arteriosus. In mature adults and in children, this develops into just a tendon that connects the pulmonary trunk with the aortic arch. But before you're born, it is a vessel that connects the two. You have two major arteries that come off the base of the aorta, right above the aortic semilunar valve. The one is the right coronary artery, which is going to form the right marginal artery. And the posterior interventricular. So, well, it can be either way, but oftentimes it's the posterior interventricular artery. The left coronary artery comes off the other side. Think of coronary as being a crown-like. So these are coming off, going around the base of the heart. Left coronary arteries gonna come off right about the same place the right coronary artery does, right immediately after the aortic semilunar valve. And it's going to become the anterior interventricular artery going down the anterior side surface of the heart, interventricular meaning in between the ventricles. And the circumflex artery. I like to think of circumflex as being a circumference. This is going to make up the outer edge on the left side of the heart around the base. Looking at the back of the heart, right ventricle, left ventricle, left atrium, right atrium, inferior vena cava, superior vena cava, the right pulmonary veins, the right and left pulmonary veins, the right pulmonary arteries, the left pulmonary arteries, coronary sinus. What's a sinus? Sinus is a really big open cavity. In the case of this is kind of like your sagittal sinus. And that it's a big vein where blood tends to pool before it's going to return to the right atrium. Right here that's not labeled, the right marginal artery, the small cardiac vein. Posterior interventricular artery. Posterior because it's on the back, interventricular because it's going down in between the ventricles. Running with the middle cardiac vein. Questions? Clean up the internal surface of the heart. The right atrium, the left atrium. The right ventricle, the left ventricle. Left ventricle has a lot more muscle around it. Why do you think it would have more muscle around it in comparison to the right ventricle? Why do you think it would and should have more muscle around it? The left ventricle. Did I mess them up? You guys, let me reverse my wording. My mother's saying I reversed my wording there. Why would the left ventricle have more muscle around it than the right ventricle?
Because to get it back to the heart.
Say it one more time, Martin.
It has to do more work to get the blood back to the heart.
Now, why does it have to do more work?
Because it's pushing it from low to high.
Yeah, but why, but the right ventricle's doing that also. What else, what other reason could there be? Hold on to it for 1 second and we'll answer that question. I was wondering if you would remember from lab, but we're not going to worry about it for 1 second. Martin, I'm going to make you answer in a second here. You're going to be so happy that you volunteered for that question. Right atrium, left atrium, tricuspid valve, bicuspid valve. Try before you buy. This is also called the mitral valve because if you've seen a Catholic mitral, I think that's what they're called. That it looks like a mitral's hat. I'm gonna scroll back just a little bit. Bear with me here. Three things that drain into the right atrium: the superior vena cava, inferior vena cava, and right over here that we don't see here would be the opening for the coronary. Excuse me. Opening for the coronary sinus. These little white strings that are holding down the tricuspid valve and the bicuspid valve. They're called chordae tendineae, meaning heartstrings. And the little muscle attachment points on the endocardium where these strings attach are the papillary muscles. Also within the two ventricles, on the internal surface of the heart, you see these major bars. These looks like little bars, sort of all on the surface of the ventricles. They're called trabeculae carnae, which means bars of flesh. Just like you remember when you studied bone anatomy, the trabeculae. Here these are trabeculae carnae, meaning rather than hard bones, these are fleshy muscle bones. Or rather than hard bars, these are fleshy muscle bars. So pathway of blood flow through the heart. Zoom out just a little bit. So blood enters the right atrium from the superior and the inferior vena cava and the coronary sinus. And it flows just because of gravity. at this point, at this moment. It flows. Remember, blood is flowing like water. It's got the same dynamics as, almost the same dynamics as water. So it's flowing from one area to the next area, the right ventricle. I want you to really think about that. Make sure that in your head, blood, water, because you know, and you've known since you were in kindergarten, the way that water runs. Apply the same philosophy here. And this will make a lot of heart physiology easier for you. So blood is going to run from the right atrium into the right ventricle just because of gravity. Initially. And then just to help, just a little bit of a help, the atria are going to contract at the very end, just to squeeze just a little bit more blood into the ventricles. And then the ventricles are going to contract. And the blood is going to move up into the pulmonary trunk. And out through the pulmonary arteries to the lungs. We're pushing it against gravity, but if we contract, so we have a lower pressure down here, or lower pressure down here, blood is going to move down. Once we contract, higher pressure down here, lower pressure in here, the blood is going to move out. After the blood gets oxygenated, it comes back via the pulmonary veins into the left atrium. And just like before, it's going to flow down into the left ventricle, just by gravity alone. And then the atria are going to give a little bit of a squeeze and just get a little bit more blood down in the ventricles. And then the ventricles are going to contract. And the blood is going to move out into the aorta. You're essentially making a cross out, bring it back in, and you go out. So when the blood comes from the body, it's going to go through the tricuspid valve first, the pulmonary semilunar valve second. When it comes back, it's going to go through the bicuspid valve and then out through the aortic semilunar valve. Questions? Okay, put these in order with the way the blood flows. Right atrium, left atrium, tricuspid valve, left ventricle, right ventricle, bicuspid valve, aortic semilunar valve, pulmonary semilunar valve, pulmonary veins, pulmonary trunk, lungs, pulmonary artery, aorta, systemic circulation. So I'm going to stop sharing. Actually, let's not. Sharing, let's come back. Tell me the order. Where does it, how does it come in first?
Right atrium.
Right atrium. And Kevin, what three vessels are bringing it in?
Oh, ooh. Good question. How about pulmonary vein?
Nope.
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 Oh,
Well, that's
how
gonna
about
be the left
how about
atrium.
the vena cava?
Yep, it's gonna be the superior vena cava and the inferior vena cava, and what else? That's not shown on this picture, but it's shown on this picture. The coronary sinus back here. It's going to drain also into the right atrium. So moves into the right atrium. Where does it, what valve does it go through next? To go into the right ventricle.
That would be the tricuspid valve.
Good, you guys are smart. Tricuspid valve. And where from there, where does it go next, Martin? And it's just flowing by gravity.
To the right ventricle.
Right. And Martin asked me a week ago to get you guys start sending out emails about dates. Martin, I will get that done this weekend. I'm going to see if I can't just set it up for the rest of the semester, but I will do it this weekend. So right ventricle, from the right ventricle, what valve does it go through then?
It goes to the semi-lunar valve.
Which one?
The aortic.
Nope. You're close.
Pulmonary.
Pulmonary. And because it's going to go to the pulmonary trunk, and think pulmonary meaning lungs. So it's got to go from the right ventricle out to the lungs. That's why it's going to go through the pulmonary trunk. So pulmonary trunk, then what, where from the pulmonary trunk, where does it go? Someone besides Martin and Kevin.
Would it be the right and left arteries and to the lungs?
Right, the right and left pulmonary arteries and then to the lungs. And where does it, how does it come back? What brings it back?
The pulmonary veins to the left atrium.
You guys are really smart. Left, okay, so left pulmonary veins, left atrium. And someone besides Becky, Kevin, and Martin, what valve does it go through next? What valve does it go through next? It's going to go through the bicuspid valve. And then what ventricle is it going to go through next? What ventricle does it drain into as it's flowing down the mitral bicuspid valve. What ventricle is it going into?
The right,
Think the reverse,
the left.
the left ventricle. And from the left ventricle, Claire, where does it go to next? What valve does it move through?
The tricuspid.
Nope, nope, the tricuspid is here.
Okay.
What? It's a semilunar valve and it's not
Oh,
the
yeah.
pulmonary.
The aortic.
It's the aortic because then it's going to go out to the rest of the body. I thought that was going to be hard because it was only like 2 weeks ago that we went through that. I thought it was going to be harder than it actually was to do that with you guys. You guys are smart. So blood is going to enter the right atrium from the superior vena cava and the inferior vena cava and the coronary sinus. It's going to flow down the tricuspid valve into the right ventricle. Then it's going to flow up into the pulmonary trunk through the pulmonary semilunar valve, go out through the right and left pulmonary arteries, when it comes back from the lungs, it's going to come in through the right and left pulmonary veins into the left atrium. It's going to flow down the left atrium through the bicuspid or mitral valve into the left ventricle. Then it's going to flow out through the left ventricle via the aortic semilunar valve. Into the aorta. Why do we call these atrioventricular valves? All because they separate the atria from the ventricles. Questions about this? Right now, when we talk more about blood vessels, we'll spend more time talking about differences in blood flow in the fetus. But I want to bring up two things for right now. The foraminal valley. If you remember from a couple, let's see here, 2 weeks ago, Zena brought up that her daughter was born a preemie, and her foraminal valley, which is the fossa ovalis in the mature heart, fossa ovalis, which is a connection in between the right and left atria. And the foraminal valley is like a flutter valve that moves between the two atria. And after birth, it should close off, becoming the fossa ovalis. In her baby, it didn't close off. And therefore they had to go in and repair it. The other part of the fetal blood flow that I want you to remember is the ductus arteriosus, which becomes the ligamentum arteriosum. So let me just so that we keep these straight. foramen ovale, hole between is a flutter valve. Flutter valve between the two atria. Becomes the fossa ovalis. The ductus arteriosus which is a vessel, blood vessel, you could call it an artery too, blood vessel, connecting the aortic arch and the pulmonary trunk. Becomes the ligamentum, ligamentum arteriosum. So those are the two that I want you to remember for this chapter. Not so worried about any of the others, and we'll go through them later. Whatever ones that we need to know later, we'll go through later. So looking specifically at the coronary circulation, the easiest way that I remember these is here's the base of the aorta. Right underneath here is the semilunar valves, the aortic semilunar valve. Immediately above or immediately superior to this valve is the right coronary artery and the left coronary artery. The left coronary artery is going to become the anterior interventricular artery and the circumflex artery, which may branch off into the posterior interventricular artery. On the right side, the right coronary artery becomes the right marginal artery and may become the posterior interventricular artery. And the reason I keep saying the posterior interventricular artery may come off this, it may come off that, it depends on the person. It can come off either one. It's one of those anatomical variations. Because I spent a lot of my time stressing at one point about which one it comes off, because the books were all different. How do you remember the veins with this? This is the way that I remember them. Here we're looking at the anterior surface again. The great cardiac vein runs with the anterior interventricular artery. The middle cardiac vein runs with the posterior interventricular artery. And the small cardiac vein runs with the right marginal artery. You find the front surface of the heart, you see these vessels running down the front surface. The artery is the anterior interventricular. The vein is the great cardiac vein. The posterior interventricular artery running down the back runs with the middle cardiac vein. Why? And the other way to remember this is the anterior interventricular artery is going to feed the majority of the surface of the heart and the left ventricle. Remember, there's a lot more muscle to the left ventricle, therefore meaning it probably needs more blood. Therefore, this is the biggest artery of the heart running down the surface. If it's the biggest artery of the heart, the anterior interventricular artery, that means that it's going to run with the great cardiac vein, because that's the biggest vein to bring back the blood. The middle cardiac vein is going to run with the posterior interventricular artery, because the posterior interventricular artery is the next biggest artery. And the next biggest artery of the heart is the right marginal artery. And because it's the third of these arteries in size, it's going to run with a small cardiac vein. Now, so here I have my heart, runs like this. Here's my left atrium, here's my right atrium, here's my right ventricle, here's my left ventricle. Here's my anterior interventricular artery coming off the left coronary artery. The left coronary artery, in addition to branching off into the anterior interventricular artery, is also going to branch off into the circumflex artery. The and our really neat little aorta, a little kindergarten looking writing of an aorta. Our right coronary artery is going to branch off into the right marginal artery, and then it's going to move around the back, and become the posterior interventricular artery. Now, I should have drawn these a little differently, but I didn't. So we're going to draw this. Actually, let's see. Let's draw it in black. Here's our veins. The great cardiac vein coming up with the anterior interventricular artery. It's going to wrap around and go back to the coronary sinus back here. And the middle cardiac vein is also going to drain into the coronary sinus. And the small cardiac vein is going to drain off into the coronary sinus. And the coronary sinus, like Kevin said earlier, is going to drain into the right atrium. If you can think of it that way, coronary circulation is really easy to remember. Questions? Our lab is probably not going to be as long as other labs, so I want to continue to work with lecture once we're finished with lab, if possible. Which of the following directly stems from the ascending aorta before it branches into the circumflex artery and the anterior interventricular branch artery? Somebody go back and look. Which of the following directly stems from the ascending aorta before it branches into the circumflex branch and the anterior interventricular artery? It's the right coronary artery. It's right here. Actually, it's the left coronary artery. I apologize, left coronary artery, right here. Pericardial fluid is found between the what and the what?
Is it C?
Why do you say it's C, Kevin?
I just seem to remember that it's in between the two layers of the pericardium.
You're right. You're right. The blank performs, and this is probably not the place to put this. I'll shift this later. But the blank performs the work of the heart. The answer is the myocardium. We'll see it in a moment here, but it's the myocardium. Myo meaning muscle, cardium meaning heart, so the major heart muscle. The epicardium is the most outer part of the heart muscle. The endocardium is the most inner part of the heart muscle. The myocardium is the middle part. The blank are the superior chambers of the heart, and the blank are the inferior chambers of the heart.
C. So, yep, C.
Atrium ventricles, right. Oxygen poor blood passes through what and what?
Is it A?
The tricuspid and the pulmonary valves. Do we agree with him? Why
I
do
was
you
gonna say E.
E? Why do you say that, Becky?
Oh, because I know it goes, it's part of the pulmonary circulation.
But is it
Goes
part of
from
the aorta too?
Probably not.
It's not.
Okay.
Mar was right about that because the aorta is going to be carrying oxygen rich blood, right?
Right.
An obstruction in which of the following will cause the most severe myocardial infarction? Myocardial infarction meaning a heart attack. Part of the heart muscle dies. The left marginal artery, the left coronary artery, posterior interventricular branch, or the anterior interventricular branch or the circumflex branch. Let's look at the circulation. Where would a myocardial infarction be the worst if there was a clot?
Would it be the left coronary artery? Because that branches out into other things.
You're really smart. Why do you, because he explained why too, because it's branching off, and it's branching off into the left, the anterior interventricular artery and the circumflex artery. It's also, if you think back to what I said earlier, the anterior interventricular artery is the biggest artery that's running down the surface of the heart. Therefore, if you get a clot in the left coronary artery, you lose all blood flow to the anterior interventricular artery and all blood flow to the circumflex artery. That's why it would be the most severe. Let's see here. Okay, I should have put this earlier, but myocardium, middle layer, endocardium, endothelium, and areolar connective tissue. One thing that we'll talk about is when endothelium, meaning the epithelial layer lining of the internal surface. This is the same endothelium that lines all the inner lining of all blood vessels. So it's continuous. The epicardium, which is the visceral layer of the serous pericardium. Remember that right out here would be where the pericardial sac would be with the, or this would be where the pericardial fluid would be. And right out here would be the parietal pericardium. So the muscle, the part of the muscle that does the most amount of work for the heart is the myocardium. Looking at heart muscle per se, heart muscle is intercalated discs. Okay, heart muscle, well, actually, let me back up. From last semester, what's the difference? What are the similarities between skeletal muscle and heart muscle?
The striations.
It's striated. What and what's something that makes cardiac muscle different from skeletal muscle?
The intercalated discs.
The intercalated discs, right. Why do we need the intercalated discs?
Because of the gap junctions.
And what do?
They allow for passage of ions to like it's a quicker synapse, right?
Right. And why is that important in the heart? Why don't we have that in skeletal muscle too?
Well, because the heart needs to act quicker.
Does it need it needs to act quicker, but what it needs to do, it needs to be able to work in synchronous, right? And so that's what those intercalated discs allow for. Is the passage of ions allows one muscle to communicate with the next muscle and allows for a flow of ions. It's going to be important in a moment. The flow of ions. When did we talk about the flow of ions last semester? When were we really worried about the flow of ions last semester? Remember when we talked about action potentials and membrane potentials? These are critical with the heart function. I do want to spend some time in lab today talking about lecture because I want to get through this part at least. And you'll see that we talked about action potentials and membrane potentials last semester. And they're very similar here with a similar function. One thing that I want to mention here also with the muscle is this is the apex of the heart. When the blood is flowing out of the heart, it's running like this. It's running like this. Here's the apex, and when it contracts, it's going to go like this. Go like this. What's going to happen to the blood when the bottom goes like this and it just screws in a little tighter? It kind of screws as it contracts.
Pushes it out.
Pushes it out. How does it push down here, or does it push it up here?
Up.
It's going to push it up. So it's kind of like wringing something out. The same way you would think about, like I said, just keep thinking about blood as running like a fluid. It's going to run it out the top. And it's just kind of gonna, it's going to be the same way. It's going to go and it's all going to flow out the top. Is that clear?
Yeah.
I was never a big physics person, but this is really basic physics. And if you can learn it, it'll make your life easier. Like things went from a high to a low. If you're gonna, just like wringing out a washcloth, you wring it and it's all gonna spiral out. I always seen this. I don't know. You guys see the PowerPoint? Okay. 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 So electrical signals pass between the cardiomyocytes. Cardiomyocytes, what do you think cardiomyocytes means?
There are cells within the heart.
What kind of cells, Claire?
Muscle. Myo
Yes.
means muscle.
You're awesome. Yes, that's correct. So cardiomyocytes, meaning that and so before I give away the answer, which I just may have done already, What's the answer here?
A.
It's A, gap junctions. And I think that this is a good place to stop right here. So I want to spend a little bit more time talking about this in lecture. We'll go through lab. You'll see if you look at the lab PowerPoint, it's not very long. And I'm trying to work better in lab to work better with the textbook. I'm learning some things about the textbook, which are going to help me make the labs a little better for you and make them less difficult and less trying for you, hopefully. But I will see you in about an hour and 20 minutes.
Have a nice break.
Thank
You
you.
too.
See you then.
Thank you.
Yeah. Jade, are you there? Alexa? Alyssa? Okay, I'm going to sign off.